Thank you very much. So I think I'm going to be the last speaker here, and thank you for holding on as last speaker in this session. Thank you to the moderators. Excellent. Well done. I'm trying to actually not keep you up too long. I was asked to talk about periprosthetic fractures, and I think this is a growing concern in Europe and also in, especially in Germany, where we have seen a doubling over the past 10 years of the cases, and that's going along very well with figures that we get from the United States. The problem, and I apologize for the German picture here, but I think the problem in these patients is that they have a lot of comorbidities. They often come at midnight on a Friday afternoon or Friday late night, and you don't know what to do, and if you can really optimize these patients. So you need to be careful about how to treat these patients, and I'm going to talk a little bit about that, but I'm also going to talk about technical issues. So we have a good paper here that I've actually listed up, and you see the incidence of fractures, cementless versus cemented prosthesis, depending on the age group where you actually place your primary implants. You have, of course, a higher incidence in revision cases, which I was really surprised to see. I mean, if you look at the revision cases that we're doing in our institution, I think that we don't see 20% of periprosthetic fractures intraoperatively, but they do occur, of course. Then postoperatively, we have to take into account that patients actually suffer from fractures as well, and that's the number that I was talking about, those doubling of the figures in 10 years frame time. And then only a tenth of these periprosthetic fractures are acetabular fractures, so I'm not going to really talk about that. The Vancouver classification, I'm not going to go through very much. I think you're all aware of that. I think the big problems are the B2, B3, and those are the cases we are going to talk about. The C cases are the ones that we are not yet really fully resolving, but I think there's new implants on the horizon. Which fracture, which procedure? Again, I apologize for the German publication, but I think this is giving you a very nice overview of how you should treat periprosthetic fractures, and we are going to talk about those ones. The ones where we do a hip revision or a hip revision along with additional procedures like a strut graft. So those are the cases that I was asked to talk about. The other classification that I would like to mention is the one that actually is now becoming more and more familiar. We are not really using that one. It's still the Vancouver classification that we are using in my hospital, but the classification from Faris Haddad and Clive Duncan is basically coming up in the literature. You can actually find that publication free for download in on the Google website. The key messages I would like to give you in this presentation is that we treat these patients probably more often according to the surgeon's experience, which often varies when treating these. And if you go to Germany, we have people that are specializing in trauma surgery, and then we have people that are actually specializing in revision surgery. And probably if you end up in one of either groups, then you're going to actually get a different treatment in a lot of these cases. The point being made, though, is that you should be aware of the fact that according to the literature, more often the implants are loose when the patient arrives in the hospital. So what you consider to be initially maybe to be a stable implant, in the sequence of radiographic follow-ups, frequently presents as a loosened implants already at the time when the fracture occurred. So I'm a revision surgeon, so probably I'm the right one to talk about that. Patients should be classified and treated adequately, I think. The challenges, of course, are not only the comorbidities, it's also the post-operative regimen for the patients. How do you treat these patients after surgery? How old are they? Can they partially weight bear, or do they need full weight bearing right after surgeries? Did the prosthesis work before the fracture occurred? Is the prosthesis, of course, fixed or loose? I think you all agree that this revision prosthesis will be loosened. And can the fracture be reduced at the time of surgery, no matter if you do a revision hip or a femoral component or not? And if you look at bone like that, then you're probably all aware of the fact that not all of these patients can be treated in a cementless way. My suggestion would be in preoperative planning-wise that you actually suggest to perform long radiographs in two planes, because there's always a bowing of the femur. You want to actually see the deformity. You want to look at the type and location of the fracture, get proper implants, look at what you got in stock if you have all the implants available that you think that you need, but you need additional things. I was speaking about that. You might need plates, cables, wires, depending on what you prefer to use. I suggest you use fluoro during the surgery and think about the approach. I think that's one of the key issues, and that's one of the problems that I'm having with the DAA and revision. I've seen patients, quite a few of our surgeons in the neighboring hospitals are now doing DAAs, but as soon as they suffer a complication, there's a big mess, because then all of a sudden they have to do swinging, skin incisions and whatsoever, and then actually get those irritations of the nerve that we all know about. So I don't think that this approach is recommendable in those bigger surgeries. So those are cases that are just coming up, and my preferred approach, of course, is, I must say quite honestly, the posterior approach, which I don't have a problem with. The preoperative planning actually includes the quality of bone. I think I'm looking at the isthmus here. I'm looking at where I want to place my components. Is the isthmus still intact? Is there still good bone stock here where I want to actually place my implant, or is a fracture running down there so that I don't have any proper place to fix a new revision head? I would like to actually get a good proper fixation of around about 4 centimeters of my new implant inside the isthmus, so that is required. It used to be 8 centimeters, but I think with the modular implants that we have available nowadays, or monoblock implants even, we can easily get shorter on the fixation. In Europe, we are very much pursuing the concept of Wagner, and I'm sure you're all aware of that. The distal fixation and the sort of remodeling, the concept of rotational stability and integration distally has been well proven. The problem with Wagner's stem was actually that he was actually placing those stems very much distally, and that actually led to the fact that they were frequently subsiding or did have 3-point fixation. So nowadays, we actually see better implants. They are modular, or maybe even sort of bent or having a kink, which actually allow them to be used in also slightly deformed fractures or femurs. This is an example. You see the follow-up, and it shows very nicely how the bone of that comminuted fracture on the proximal femur can really very nicely remodel. The concept behind that is that you don't try to strap the bone from the soft tissues, but you try to leave everything intact, very much like you would do in a fracture fixation. This is another case, fall in the bathroom 2 weeks post-surgery. This is this Portorno stem, which is really dangerous when it jams into the femur and actually causes these fractures. Quite easy, you do the planning on the opposite side, because that's where you get the better idea of what the fracture fixation should look at. A cable, a couple of red wires around it. You take a cementless, maybe modular stem. Doesn't matter if you want to do a monoblock or a modular stem, and then actually fix that fracture, and it's going to heal without any major issues. That is a quick surgery. You go in there and the patient can walk day after surgery, get out of the bed. Another case, and this is just to show you that there is monoblock stems out there that you can actually utilize to actually do anatomical reconstruction. I think all of you would agree that this stem was definitely loose. So I suggested to you that you should use those 2 long-standing x-rays, because very frequently you see those cases coming in where you actually have had a failure of a fracture fixation. You see that there is bowing in 3 planes. Not only the varus, but it's also a rotational problem, and also the anticurvation. And that what you see on the right side is often what you see in the books, a straight femur, but that's not true. I think we all need to be aware of the fact that there is a significant amount of bowing on the femur. And the prime problem that we are seeing with those longer stems, cementless stems, is that they actually might run and jam up against the anterior cortex if you have that bowing. So I would suggest you that even when you're using fluoro, when you do postoperative x-rays on these cases, you better take a very close look, because what you see here is a crack on the femur once you have taken care of fractures that actually ran down, but that's a fresh fracture that occurred intraoperatively. And if you don't catch that, patients will get up and walk, and then all of a sudden you will have a mess, and you will have to take that patient back into the OR. If you treat them conservatively and you've seen the fracture, then they will heal without any major problems. What about bad bone? And that's basically the final picture that I'm going to show. This is a guy that actually had a slowly increasing fracture periprosthetically, and you see that this is a very poor bone stock elderly patient. You ask yourself, what are you doing? Once again, you can see there is this bowing of the femur. There is also varus remodeling of the femur. And in those cases, what I normally do is I like to actually go back and take a selection of broad and longer cemented stems. And the one on the right side I would like to point to you is the one that I actually prefer in those situations because it gives me the permission to straighten out the whole femur, make it straight, and actually take a very long cemented stem and actually drop cables around it and fix these patients. And again, you see that there is dual mobility in this patient because these patients, as I mentioned before, often present with comorbidities. Another case, he fell, and that's one again that I wanted to show because I wanted to point this arrow down there. I was planning for cementless implant, but then when looking again on the x-rays, I'm going to go back. You see that this fracture, which I thought was going to end further upwards, was actually winding down all the way to the distal femur. And that made it actually again necessary to actually use a long cemented stem. You see that the fracture is actually ending up down there, which then actually allowed me to do anatomical reduction and a long cemented stem. So my conclusions would be you have to optimize the patients. These patients, I think you should not treat around midnight, and you have to have a well-rested team. And that gives you time to prepare these patients properly for the surgery. You need to get adequate radiographs. You look at the bone, you make sure that you have the right implants available in the OR. You prepare for plan A, B, C. You need to pick the right approach. I have seen more than one failure because colleagues of mine tried to use the wrong approach, and you need to pick your implants carefully. Thank you very much.